The Prix Galien is a welcome initiative to stimulate creative research and promote excellence. Barack Obama. The Galien Awards ceremony is considered the equivalent of the Oscars night for the innovators in the labs and awards every year the best pharmaceutical product, the best biotechnology product, the best medical technology, and the best digital health product.
This is the right event, on the right issue, at the right time.
I thank His Excellency, the President, for bringing Prix Galien to Africa, and I look forward to the day when we will celebrate an African winner of the Prix Galien.
I'm particularly grateful to receive this award.
The awards are among the highest honors in science and commerce because they lead to improvement in the human condition.
The Prix Galien Awards recognize the world's brightest minds and most innovative companies. They are a true celebration of the hard work required to produce life-changing interventions.
That is what makes us optimistic about the future.
Congratulations to all of you.
Make a difference. Join the Galien Foundation.
Welcome, everyone, to the Galien Foundation event related to healthcare financing and delivery in a post-COVID world. And in particular, how are we going to improve the healthcare systems, the financing of those systems, and the delivery of care to make sure they realize all the ideals we want, to have healthy people, to have reasonable costs for society so we can have all the other things we desire, and to make sure it's equitable, that everyone can get access to it. If COVID has proven anything to us, it is the importance of healthcare interventions like the vaccine to bring us back from the brink of this pandemic. But it's also shown some of the inequities in every single country, whether they're by race, income, education, or age. We have an unbelievable audience here representing 45 countries on 6 continents. And we have the most illustrious panel you can imagine to address this very important problem from an eclectic set of viewpoints. And I will say, I am looking forward to this because I think every health policy expert is thinking about how can we make changes to the system going forward. So the next thing we're going to do is to have a little poll for you in the audience to begin engaging in our discussion about how you think we can actually improve healthcare financing and delivery. The question is, what's the largest obstacle to improving healthcare systems and outcomes? We have several answers for you. Please select them. And while you're thinking about them, I'll give you a few seconds to read. I'm going to begin by introducing our first speaker. We have 4 speakers representing 3 countries, each with a different kind of healthcare system, a different method for financing healthcare, different delivery systems, although all obviously have hospitals and primary care doctors and specialist doctors and drug companies and device manufacturers and the whole panoply of government regulators. Our first panelist, and we've had a very complicated selection process for who goes first, it's alphabetical by last name, is Moshe Bar-Siman-Tov. He's was the director of the Israel Ministry of Health, and through June 2020, he led the professional response by the Israeli government to COVID-19. I will introduce each subsequent speaker after we've asked each speaker to begin with a few minutes of their thought, and then we will engage in discussion. For those of you who want to engage in this discussion and ask a question of a speaker, please put that question in the Q&A, and then we will get some of the best of those questions and ask them during the discussion. Now, before we get to Moshe, do we have the results? So we have an interesting split. Limited financial and other incentives to innovate is the top. Maybe that's not unusual in a group dedicated to innovation in the pharmaceutical, biotech, and device and digital area. Emphasis on social determinants of health is lowest here. And second is siloed approaches that impede collaboration and innovation. So still a very big emphasis on innovation and facilitating innovation. With that, Moshe, Bar-Siman-Tov.
Okay, thank you. It's a pleasure being here. And my first point is corresponded with the results that we just received. I think that digitalization is a force that we need to use much more in order to improve our healthcare systems. And I think that most of us knew it before the pandemic, but now after the pandemic, we find how efficient it is in order to make our systems better. So I think that we must move forward in implementing digital services in our system. We did it in Israel again before the pandemic, but the pandemic forced us to use much more digital services, and it's not just using telemedicine or telediagnostic. It's also using AI in order to make the right decision from the patient point of view to the policymakers as well. Another thing is again to understand and to implement what we already know, that in health, equality means efficiency. We knew it before, but now we know that equality also means quality. And again, we saw that healthcare systems that promoting equality dealt better with the pandemic and the outcomes. It's not just that they did it in a more efficient mode, the outcomes were better as well. And I'll say it, maybe it might sounds a little bit bizarre, but I think that we shouldn't be afraid to be in more social or even socialist orientation through healthcare system. To be in the scale of, let's say, the pure market-oriented system and the socialist-oriented system, we can move a little bit forward to the socialist mode. Not to be afraid. It doesn't mean that we are becoming socialist country or communist country. Israel is a market-oriented system, but we do believe that using this approach means better use of our resources and better health for our population. And we also know that, again, in pandemics, but in other aspects of our lives as well, nobody's safe until everybody is safe. And again, in a stress test like the pandemic, I think that everybody felt it very strongly. And the last point is finding new ways to implement the health in all policies. And we used to think about health again as health, as hospitals, clinics, payers, providers, etc. But I think that we need to take more preemptive approach to take the right decision, and it means to get to taxation system, to get to the urban planning system as well. And I can give you one example from Israel. We started about 2 years ago a food labeling system in Israel. I'll try to show it to you. Well, it's hard to see. Let me try to improve it in a way. But what we did is we took, so now you can see the background of my room. So now you can see that in this product, this is a chocolate. you can see that it's labeled in two red labels. That means that there is high level of sugar and high level of saturated fat, and there is also label for high level of sodium. And believe it or not, there are products that has these three labels in the same product. But this is generally speaking about looking forward to the next decade or so.
Great, thank you. Next, from the United Kingdom, Sir Michael Marmot, who probably needs no introduction, but he's the director of the Institute of Health Equity at the University College London. He chaired the WHO Commission on Social Determinants of Health and has focused, in addition, on commissions in various WHO regions, such as Europe, the Americas, and the Eastern Mediterranean. Sir Michael.
Thank you. I note your poll, social determinants ranked low. On the other hand, I have to make a methodological point. You advertised this meeting as restructuring health system financing. What did you expect? If you'd advertised the meeting as creating greater health equity through action on the social determinants of health, you might have got a different result. So I want to start where Moshe ended up, which is on what he called health and all policies, which I would call the social determinants of health. And the first point I want to make is that pre-pandemic, let me take the example of two countries, the United States and the United Kingdom. Health had stopped improving in the UK, life expectancy improvement, which had been about 1 year every 4 years for 100 years, in 2010 slowed dramatically. And in the US, life expectancy actually declined. So here we have two rich countries. One spends gazillion dollars per person on healthcare. The other one spends much less, but has universal access, free at the point of delivery, and both doing very badly, not because of the healthcare system. You could restructure, refinance the health system all you like, and it wouldn't have solved that problem. Related to the slowdown and improvement, or indeed decline, was increase inequalities in health. And in the UK, we actually had health declining for the poorest people, as you did in the United States. So this was a miserable situation pre-pandemic. And the evidence that I've reviewed in my various commissions says that such a health situation is not simply due to defects in the healthcare system, but in society at large. So the second point is that I authored two reports with the same title, Build Back Fairer, not better, but fairer. The first one was in the UK because we said that the pandemic would expose the underlying inequalities in society and amplify them. And so it proved. And the second was in the Eastern Mediterranean region of WHO, North Africa and the Middle East. And my fellow commissioners, I chaired the commission, my fellow commissioners said, we like the title, Build Back Fairer. We want to give our report the same title because the status quo pre-pandemic was far from ideal for the reasons that I've said. The two countries I mentioned with a slowdown and improvement in health, but many countries around the world, and particularly in the Eastern Mediterranean region, with increased health inequities. Build back fairer. If you look at the social gradient in mortality from COVID-19, I did the experiment today. I produced the same graph for oral health, and it shows the same social gradient. The more deprived the area, the higher the ill health. You think, what's going on? COVID-19 is caused by a virus. Oral health is caused by diet, fluoride, whatever. And yet they show identical social gradients. which means if we want to deal with the pandemic, if we want to deal with oral health, if we want to deal with diabetes and cardiovascular disease, we've got to deal with the social determinants of health inequities. And that's why I called my report Build Back Fairer. And the third point that I want to make is it relates to what Moshe said. My overall recommendation is to put equity of health and well-being at the heart of all government policy. Food labeling, great, but I want us to invest in early child development and education. I want us to invest in improving working conditions. I want everybody to have at least the minimum income necessary for a healthy life. I want us to invest in local communities, housing, neighborhoods, and indeed label food, take a social determinants approach to prevention. And a more equitable healthcare system needs to be a partner, but it needs to be within the context of addressing the social determinants of health inequities.
Thank you very much, Sir Michael. Next is Dr. David Nash. He was the founding Dean Emeritus of the Jefferson College of Population Health. Now he's the grandson, is that what I have? Great chair of health policy at Jefferson, where he has been on the faculty for over 30 years and advising the CEO of the whole Jefferson medical enterprise, which has become vast in the Philadelphia area. David Nash.
Great. Thank you so much, Zeke. What a treat to be here with these amazing colleagues from all over the world. And thanks to everybody tuning in, too, in the middle of a busy day. Well, following Sir Michael is a large task for sure. But I want to go back to the same question that you posed to the audience. I think what's the biggest obstacle had nothing to do with any of the choices that we gave them. The biggest obstacle we have to overcome is lack of leadership domestically, lack of leadership worldwide to tackle exactly what Sir Michael was describing, and Moshe as well. So Zeke, you and I live in an amazing town, the birthplace of our democracy, but Philadelphia is also the poorest city of the top 10 cities by population in our great country. So what does that mean? Well, it means that 1 out of 4 persons who live in our town live in poverty, and half of those can't put food on the table. Sadly, also in our great town, your amazing institution, Penn Medicine, and mine, Jefferson, are 2 of 5 major academic medical centers, 2 of which are walking distance from one another. And despite all the amazing resources that we've committed to the research, education, and health care mission, Philadelphia County, where those 5 medical schools exist, is the sickest county in the great state of Pennsylvania, ranking dead last, number 67 out of 67 counties. So to me, among the greatest financial challenges we have is first the recognition of the direct connection, as Sir Michael and Moshe pointed out, between poverty, lack of access, disparities in care, structural racism, and all of the challenges that the pandemic shined a bright light on these issues. So what I'm hopeful about moving forward is the following. How can anyone believe that the system that brought us to the brink of disaster, that largely contributed to the death of 500,000 Americans, how can we believe that this same system is the one that will take us successfully into the future? So from my perspective, it's got a couple of issues. 1, incredible waste in the current system. Most experts believe between 25 and 30% of all spending, which is roughly $1 trillion. So we've got to tackle the waste. 2, the financial incentives, upside down and backwards. And it's so great that we have Gail Wilensky here to talk more about these issues. We all know that if you pay people to do a certain thing, that's exactly what they're going to do. If we change the payment system and mandate aspects of those payments, we could change clinical behavior. 3, all of the disparities and structural challenges, well, we need leadership to really tackle those. This is partially a political issue, of course, but the health care system has never been in the business of improving health, especially since the passage of Medicare in 1965. We're in the delivery of service business, not in the health care, create health business. So in summary, our great city is a mirror on the nation, and how we handle the dynamic tension between 5 great academic medical centers in one city producing poor health outcomes. The reconciliation of those things is really what the future, in my view, is all about. So I'm very excited to be a part of this great global conversation. I would close by saying we have a lot to learn from our neighbors around the world, for sure. And I hope we'll be more open to some of those global lessons moving forward. Thanks.
Last but certainly not least is Dr. Gail Wilensky, who's a world-leading health economist at Project Hope and served in the United States government as head of Medicare and Medicaid, the agency we call CMS, and guided it for several years. Dr. Wilensky.
Thank you. It is wonderful to be with this distinguished group of experts. You left off one important activity that I engaged in, and that is that I was a member of Sir Michael's WHO commission looking at the social determinants of health. It convinced me, if I needed convincing, that whatever else goes on in terms of trying to improve the delivery of healthcare in the United States and its equity, we will have to focus on the social determinants of health. It is impossible to imagine making great strides in terms of health outcomes if we are also looking at the conditions in which people live and work and die as influencing the health that they will experience. In the United States, we have some particular issues that we have to deal with in terms of improvements in healthcare. We are a pluralistic health system. While the government sector is growing larger because of the growth resulting from the Affordable Care Act in terms of reducing the numbers of uninsured, the growth in Medicaid and in Medicare, we still have a sizable private sector. And that means that when we think about strategies, it has to be a set of strategy that will work in a pluralistic healthcare system. For me as an economist, it means focusing on information and incentives, and making sure that the incentives that are in place are the ones that will help us produce a better, more efficient, more equitable healthcare system. There has been increasing acceptance in the United States of what has existed outside of the United States for many decades. And that is the recognition that having universal coverage, having people have a way to be able to affordably access healthcare is very important. We may debate about exactly how to get that accomplished, but there is very little debate about the importance of having everyone covered And we have experience with our recent COVID that being outside of coverage only makes it more complicated in terms of providing services to all of the people in our country. Focusing on the social determinants of health will be much easier if we can find ways to slow down spending in the healthcare sector. It's not absolutely required, but as long as we have seen the rapid rates of growth in healthcare spending, it has tended to depress the willingness and ability to spend on other areas of social determinants. Preschool education, making sure that the housing that people have is adequate, making sure that their access to food supplies is adequate. These are areas every bit as important as medical care in terms of improving health outcomes. Whether or not we can take advantage of all that we have learned, both as a result of our COVID experience and also the work that has been done on understanding the social determinants of health, is something that we will have to see in our future. For us in the United States, we can only proceed with what the majority of people are willing to support in an electoral system. If we can move in this direction as a result of this kind of support, we could see great strides in progress in terms of improving both the health equity and the health efficiency of our healthcare system. Thank you.
Thank you, Dr.
Look forward to the
Wilensky. So
questions.
I notice a tension between the way our audience responded and the way our panelists have responded, as you've all noticed. And one of the ways of maybe reconciling those two responses is that innovation doesn't happen in a vacuum. And it doesn't all have to be biomedical innovation. It can be innovation in digital. And part of what drives innovation is what will be rewarded through the innovation. So one of the questions I want to ask, and we have many people who have both public service as well as are careful observers of public service, is, could we get innovation in the social determinants of health if we made parts of the healthcare system more accountable for actual health outcomes, not just delivery of quality healthcare services? So what I want to ask is a very specific kind of question. David Nash pointed out, we have these big healthcare systems in Philadelphia. They're all over. What if we made those healthcare systems responsible for health outcomes in their communities, in their areas? In England, what if you made the healthcare trust responsible for the healthcare outcomes, the longevity, the infant mortality, maybe the proportion of people who got to age 75 in their areas? Or in Israel, if you had the Klalits and other health plans responsible for the health outcomes of their people, you paid them for the services, but maybe held back some money that was linked to health outcomes. Is that the kind of change on financing and delivery that might be able to move and merge and therefore also catalyze innovation in the determinants of health? We're going to start with Sir Michael and then move to Moshe.
Well, we did the experiment in Britain. The government of the day introduced a new healthcare act in 2012, and it united the country. 99% of nurses, pretty well all the doctors, the Lancet, the BMJ, academics were united in condemning it. Nobody liked it. Goodness knows what they were thinking. And what the act said was, what we need is more competition, more markets, less integration, less organization. Let 1,000 flowers bloom. We want half the patients in NHS hospitals to be private patients. And I say, united the country. Everybody hated it. Well, now, without quite saying that, gosh, that was an error, the current conservative government introduced a white paper, and now they're talking about integrated care systems. Wow. They've completely thrown out the previous change, integrated care systems, and they are beating a path to my door. I can't cope with it. They're all saying, we want our integrated care systems to improve the health of our local populations. And we recognize exactly what Gail said, exactly what David Nash said. Thank you for coming to my party. You're very welcome guests at my party. And what they recognize that to do exactly what you asked for, Zeke, they need, as integrated care systems, to be addressing the social determinants of health and to monitor health and health inequities in their local patches, in the neighborhood which they serve. It's a very welcome change. It's a complete reversal for what happened before, and they're actually starting to do it.
Interesting. Moshe.
Well, first, I think that the fact that in Israel we have integrated care system, we have these HMOs, these 4 HMOs that are responsible for a whole basket of services, and they have a given budget. So I think it's basically incentivize them to take better care of the health of their population. But we are in a process of trying to implement some of the outcomes measurements in the risk mechanism, de-risking mechanism of these HMOs. We are doing it with diabetes. We are not getting to longevity or infant mortality, but you are looking at outcomes for diabetes. So whether they are balanced or not, and the HMOs, part of their reimbursement will depends on their outcomes with their diabetes population. But again, we must understand that whatever we will do, there is a limit of the influence of any healthcare system of these social determinants of health. And then we are going back to what Sir Michael said about leadership. I think that as good as your healthcare system can get, it cannot replace the whole leadership of the whole country, and putting values like quality and equity in the center of the policy making.
I have a question for you, Moshe, since you were in the government. Could you, as director of the health ministry, have provided that leadership, or does it have to really go to the prime minister level, the political level?
I think that there are certain things that you can do, certain things that you can do by yourself. The food labeling was something that the ministry led, but of course there are some measures that it involves too many powerful entities, organizations among the economic ecosystem, that it gets to the prime minister. But I think that our prime minister understood and understands that health is something that it's too complicated, and if it works, try to make it keep working. So it's good to make these amendments, and he was trusting us as a professional level at the ministry, and gave us a relatively high level of freedom to work. And it was also during the pandemic as well. I mean, we were relatively very, very involved in the policy making.
Great. David, did you want to respond?
Sure. First, I can't help but remember, who knew how complicated healthcare was, right? I love Moshe's comment. I want to go back to your question.
I didn't just say it.
I want to go back to your question, Zeke. Linking clinical outcome to payment is not a new phenomenon. Of course not. I just talked to people at places like Kaiser Permanente and many others who have been doing it for decades. So I think what we need are better, more powerful measures linking the economic incentive to clinical outcome. We popularize the saying, no outcome, no income. Now, we don't mean it in absolute terms, but clearly we could do a better job, especially in the United States, of having outcome measures that clinicians can embrace that are appropriate and that can be linked to payment. We know how to do this. There's ample evidence. We also know research that would fill the room I'm sitting in, of course, contributed to by some of our panelists, that when you change the economic incentives, miraculously, clinical behavior changes. So let's get real. We know how to do this. We need some improved measures. And as you have advocated, and I concur, aspects of this need to be mandated. When you mandate connectivity between improving clinical outcome and payment, you get even greater traction on the part of clinicians. So we know how to do this. There's ample research evidence to support it. We need the political will to mandate aspects of this. And I quite frankly think a lot of providers would welcome the opportunity to get deeper into these kinds of programs, especially if they felt that the measures made sense. So I'm optimistic that we could make this kind of connectivity happen, at least in the United States, moving forward.
Gail?
Wanted to go back to some things that Sir Michael had mentioned. It is definitely true that what Britain was seeing in the early part of the last decade proved to be not helpful. But you can imagine that having moved now to integrated care systems, as we are also doing more and more in the US, you could have both explicit or at least implicit competition between these integrated care systems. The problems here in the United States, as well as other places, is for so long the emphasis has only been on the inputs that are being used and not on the outcomes that were being produced, which in this case, of course, is health and health in an equitable provision. So I'm not sure that all of the concepts were wrong. They were focused in the wrong place, focused on the inputs, not on the outcomes, and they were not focused on the importance of integrated care systems. The other challenge, at least in the US, is that we tend to have many, many different programs that relate to both health and to other areas of social determinants of health. Decades ago, in some work that I was doing, a group of people from a variety of political perspectives believed that there was enough money in the healthcare system, but we were just not spending it well. Enough money that if it were moved around would provide the kind of outcomes we were looking for. The challenge is politically is that so many of the government programs are monitored by, with some influence, by many different committees in the US Congress or by different parts of the Department of Health and Human Services. And trying to get a cohesion between all of these parts and to have them functioning in a singular way rather than in diverse ways has, at least to date, proven beyond what we have been able to manage. It isn't that we don't have a lot of the components there. We just haven't figured out how to mobilize them in a more efficient and effective manner.
Sir Michael, can I ask you a question? Oh, you wanted to go, why don't you comment and then I want to push you on the spotlight. You're muted.
Ask your question and I'll get my comment in anyway.
expert panelist you are, Sir Michael. So I wanted to ask a question actually about the integrated delivery systems and making them focus on the social determinants as opposed to making them focus on their usual stuff, you know, running a hospital, shifting referrals to specialists, et cetera. How can we innovate to make that kind of thing happen? Take a broader view of health and what their obligations are.
Well, it comes back to the question of leadership. I mean, I don't want to contradict the importance of financing and incentives, but what we've got in the care systems that have approached me, they say, we want to do something about health equity in our patch. It might be a region, it might be a locality. They didn't say we want to save money. They didn't say we want to somehow attract more money from the government. They said, we want to improve health equity. That's our goal. And we recognize we primarily deliver health care services. That's our job. Increasingly, there's integration with the social care system, the recognition that if you can, particularly for older people, if they can be kept healthy, functioning at home, it puts less burden on the health care system. But it's the leadership of saying we've got a goal of improving health equity. The financing is important, of course, but it's not just the clinical outcomes. We had a big change in Britain where both funding of local government, I can't tell you how many people have fallen asleep with boredom when the conversation turns to funding of local government. They either get totally confused or they just pass out. But so at the risk of that happening, if you look at local authority spending in Britain by quintiles of deprivation and what happened in the decade from 2010, local authority spending in the least deprived, the most affluent 20%, went down by 16%. And then the more deprived the area, the greater the reduction. And the spending went down by 32% in the most deprived quintile. Wow. And the spending on adult social care followed that. So the greater the need, the greater the reduction in spending. Our healthcare system, as you know well, Zeke, used to be weighted. The funding had a deprivation in the weighting. The government removed that deprivation and they replaced it by age. So wealthy retirement communities on the South Coast got more funding and deprived populations in Manchester and Liverpool got less funding. So it wasn't just clinical outcomes that needs the money, it's need, and need is related to deprivation.
So can I ask you this question now? I want to just put you on the spot. Would you recommend risk adjusting or however adjusting the payment so that deprivation is a key factor in health care dollar spending? Is that the kind of leadership you're looking for?
When David talked about linking the payment to outcomes, and I thought, yeah, how can you argue with that? That makes perfect sense, except if the outcomes are strongly influenced by poverty. If people can't eat, their outcomes might be worse. We know that people who can't afford to get their pharmaceuticals don't take the pills. So you then put greater need on the healthcare system, and because they now have worse outcomes, you take money away from them. So whether some kind of weighting is the right way to do it, I'm not sure. But certainly simply looking at outcomes without looking at the social determinants, as all of us have been saying. And Gail and I must say, had a wonderful time as colleagues on the WHO Commission. We came with very different viewpoints. And by the end of it, we were talking the same language. It was quite special.
Moshe, how does Israel integrate deprivation into its allocation on healthcare?
Well, we do it, but we have a long way to go. One of the parameters that we use is giving a factor, a positive factor for periphery areas in Israel, which is correlated with the deprivative areas as well. So there are 10 clusters in Israel of periphery to center. So the 4 lowest clusters receive this factor. We also use a mechanism for a certain type of incomes that you get from the government, income assurance that you get from the government. But again, we must do it much more. We also use the medical condition for certain medical conditions. The HMOs, the payers receive a positive factor as well from the government in the risk adjustment formula mechanism. But again, I believe that we can do much more than we are doing now to take more income and functioning, the day-to-day functioning of the people, to take it into account in the mechanism as well.
So we have an interesting question from the audience, and it relates to the first point that Moshe made. Maybe the most important innovation, I think you said, was digitization, telehealth, home monitoring, and such, using AI on patient records. So one question is, would that, in anyone's view, help narrow the health equity gap, or is that just investing in healthcare and ignoring the social determinants? I'm going to throw it open and
well,
I don't think in and of itself it will correct the issues that we've all agreed are out there. They are ways that if you also account for the different outcome factors we've been talking about, improvement, performance, need, however you define that, that these are strategies that can help us get there, but in and of themselves are not going to resolve the problems that we have been raising. It could even worsen them in the short run if there isn't an active measure made to make sure that the digitization and the telehealth and the AI go to the populations most in need, or the issues that most need to be focused on, but then disseminated in a way that takes equity into account.
So Michael, you're sort of shaking your head.
I'm approving. I agree with Gail.
So you think digitization is more likely to widen the gap rather than narrow the gap?
I agree with Gail exactly. If you put health equity at the heart of all that you do, you evaluate an innovation with regard to its likely impact on health equity. So you make that a prime aim of your innovation. And if digitization helps with that goal, great. If it winds it, not so great. Look for one that does. So I think that's what Gail said, and I'm agreeing with her.
We found during the pandemic, Gail and Sir Michael are totally right. Jefferson had a very large telemedicine capability, even pre-pandemic, which we then, relaunched. But of course, in the minority community, we were not engaging as deeply and widely as we thought we were. So I think paying attention to Sir Michael's right, if you start with the equity discussion, that will guide the policies and the procedure and the resources necessary. So I think next time around, we're going to be a lot more cognizant of which communities we connect to, how we do it. Oh, and by the way, asking them what's important to them instead of saying, hi, we have the answer. I think it's a humbling experience for sure.
Sir Michael.
Well, if I could take an example from another field, we in the UK had, I think, what you had in the US with education, charter schools, and we had the equivalent of free schools, taking them out of local authority control. And well, in fact, they became part of chains. But initially I was asked, what did I think about that? And my response was, what's the likely impact on equity in education? That's what I think about it. I was agnostic. I didn't think they were good or bad. I wanted to know what the likely impact was on equity in educational outcomes, because that's so key to health. And that's still my view about it. I don't have an ideological commitment to whether a charter school or a local authority controlled school is a good or a bad thing. I'm concerned about the likely impact on equity. In practice, what happened was the free schools, I don't know what happened in the US, but in the UK, they were established in middle-class areas. So they competed with the local authorities schools in middle-class areas, and they weren't established in areas of deprivation. So they were very unlikely to improve the problem of deprivation and inequity in educational outcome, which is key.
Of course.
Yeah, I'm not sure that's the necessary story in the United States around charter schools.
Not in Washington.
I was going to say not in Washington.
In Washington, charter schools have been very important in providing an alternative educational mechanism for children in some very low income neighborhoods.
So we're, I think, agreeing that what we're saying is that the judgment should relate to equity of outcome, not some prior commitment to how it should be organized, but what's the effect on equity of outcome, in this case, education.
Exactly.
Good. So one of the things I wanted to ask is whether in the United States, we've tried an experiment now. We haven't labeled it an experiment, but we've let our Medicare Advantage plans, which are plans system insurance companies that take care of the elderly and have a fixed fee capitation to take care of them. They now have the ability to spend some of that money, not on healthcare services, but on things like housing or transportation or food for their patients, their enrollees, in an attempt to boost their healthcare. Do you think this is a good experiment, Gail, or not, in terms of trying to address the social determinants of health? Or is this another mechanism by which health insurance companies just become richer?
I think we will see how well it works. The concern I have is that the base payment for the Medicare Advantage was kept the same, but what the groups were allowed to spend on, in this case, some of the social determinants of health, like food and housing, was included in the allowable spending categories. Unless you think there is enough money that can be pulled off from more efficient ways of providing healthcare by focusing on housing and food, I'm not sure whether the amount of money that is available to the Medicare Advantage plans will allow both the provision of all of the Medicare benefits, which is what's required by law, and also be able to have much money left over. The structure, however, might be an important structure that is already doing outreach to large numbers of the Medicare population and growing. And so it could be viewed as a means of trying to include more of the social determinants of health. I suspect the way it is structured now, that not much money will be available, And so the impact isn't likely to be very great, but it is definitely worth assessing. It was just going into effect in 2019 and 2020. And so 2021, 2022 might provide the first glimpses as to whether anything observable can be seen as a result of this greater flexibility being given to the Medicare Advantage plans. So good idea, good structure. I'm not sure that the money's going to work.
Okay, well, we just have a few minutes to go. So I'd like to ask everyone in a final thought, if you were the leader and could mandate one thing to improve the financing and delivery post-COVID, what would that one thing be? And please keep it to one thing. I know all of us have a very long laundry list. I, like you, have produced lots of memos with laundry lists for policymakers. One thing. So we'll start, Moshe.
Well, since I have, I don't have enough time to think, but I would think that something that you really can implement is to invest more in in-house related treatments. I think that if we are looking forward, the aging population and the insufficiency of every healthcare system around the world, this is a major part of the solution moving forward to the community, and from the community to the arms of the patients. And it takes, you really need the digitalization embedded in it in order to do it right. So
okay,
I think that I will go for it.
Sir Michael.
If I'm only allowed one thing, it would be everyone in government should read my Build Back Fairer report and implement all of its recommendations.
That's very creative way of getting multiple recommendations in under one.
Great answer.
Dr. Nash.
Equity of health and well-being at the heart of all policy.
I certainly agree with Sir Michael, but my one thing would be, at least in the United States, duplicate what's gone on in the great state of Maryland and try it in multiple states, because we know the research evidence is that global budget system has produced better outcomes at a lower cost.
You mean the global budget for hospitals?
That's correct.
So give hospitals a global budget, regardless of how patients are insured, so that they have to care for the population, not service by service.
Right. Perhaps not every state, but let's expand that and see what happens.
Dr. Wilensky.
Probably not what people would guess, I would say, but it is universal coverage in the sense of making sure everybody has access to some type of care, and outside of healthcare, early childhood development.
Indeed. Right.
Great. That is wonderful. I think we have come to the final bit of our time. If I could just pick up on Gail Wilensky's last comment, it is the case, actually within the American healthcare system, that we could give early childhood interventions, nurse-family partnerships, so right postpartum to parents and children who are deprived. These early interventions, the earlier they're done, the better. And they produce, certainly in the United States, decreased healthcare spending, increased education improvement, less interaction with the criminal justice system. We could give them to all patients who are on Medicaid, people who are basically below the poverty line or below 133% of the poverty line. And that is feasible. It's about $200 billion over 10 years. And it could be done through the healthcare system if we wanted. So that's, I think, creative. And we know that has a long-term positive impact on equity by investing in children. With that, I want to thank the Galien Foundation for bringing together this wonderful panel. And I hope that we have brought at least closer together the idea that we can focus on social determinants of health and health outcomes with innovation and give structure to those innovations that intersect with the healthcare system. Thank you very much to everyone on the panel.